nonlinear psychoanalysis, um, notes from 40 years of chaos and complexity theory, and the essential other, a developmental psychology of the self. Dr. Galatzer-Levy is consulted with us routinely. He's a widely sought after consultant, and I think you'll find his thinking, or I always find his thinking, sort of creative, engaging, and very relevant. So with that, I'll turn it over to you, Dr. Galatzer-Levy.
Okay, and if you will all hold on just a moment, I will open my own notes, which are helpful. Okay. First, may I make a request that those of you who are here keep your cameras on. I'm going to be trying to talk to each and all of you at the same time, and it's easiest to do that if I can see you. So please leave your cameras on. And I also want to very much thank Yellowbrick for inviting me to give this talk. It's part of really a very wonderful ongoing effort that they make to provide significant talks and ideas to the whole therapeutic community. So with that in mind, let me tell you what I'm going to try to do this evening. There's an incredible amount of talking about race and ethnicity in the therapeutic community, but at the same time, translating that into something that's practical and useful for the working clinician is sometimes quite difficult. And what I'm going to try to do is talk in a way to any kind of moralistic judgment. I will assume that everyone doesn't want to be racist and whatnot, and I don't think talking to people and telling them you shouldn't be racist is a terribly useful activity. What I'm going to try to do instead is to talk about, from a clinician's point of view, are there a group of useful ideas that can help us be better clinicians in the area of ethnicity and race. And so let me start with a story. I'm going to mostly use examples that are drawn from my own clinical experience for two reasons. One is that I know them well. The other is that I want to communicate the idea that the challenge of dealing with race and ethnicity is essentially universal. That is, it's a challenge for all of us. And rather than talking about what other people do badly or well, I'll use myself because I've done any number of good and bad things in this area. And so you'll forgive me if this has a lot of autobiography, but I think that might be a better way of talking than pronouncing things from on high or telling people that they ought to do otherwise than what they do. So I'll begin with a clinical experience that occurred about 35 years ago now. I was asked to treat an adolescent boy who's was giving his parents a lot of trouble. That's that's sort of the standard stuff of an adolescent psychiatrist. And as I always do, I invited the parents to come in and talk to me initially. And into my room walks this statuesque, beautiful, tall, blonde woman who carried with her a name which was identified European ancestry. And when she walked in, she looked at me and she said, "I'm not who I look like," which kind of startled me and which got me thinking, because indeed she wasn't who she looked like. That is, she wasn't the person she reasonably assumed that I would think she was based on racial and ethnic stereotyping. And I was aware when she said that I made a bunch of assumptions about who she was based on these very superficial features. Now, remember, this was 35 years ago, and this was really quite a remarkable thing for this person to do. And I learned a lot from that. That was a valuable lesson to me. That, by the way, is going to be another theme of what I'm saying. The people we can learn from best, if we let ourselves do so, are our patients. Our colleagues, our techs can maybe inform us of ideas that are useful. But it is our patients, if we listen to them, who will teach us most and will provide us the opportunity to learn from experience, if only we let them. So let me tell you where I'm going, and so you can be oriented. I'm going now. We have a little less time than we originally anticipated, but I'll talk for on the order of 45 minutes or maybe a little less, and then I'm going to invite you to either say what you think of what I've said, or ask questions, or enter into the spirit of conversation, which is the title of this. And where I'm going is first to underline that my goal is to talk in ways that will be helpful to you as therapists. Although I have very, very strong feelings about these issues, I'm going to do my best not to try to believe what you should feel. I'm simply going to say, if you want to work more effectively as a therapist in a world where ethnicity and race are important psychological realities, then here are some ways to think that I believe will be useful to you in achieving that goal. Now, I'm going to talk about roughly 5 or 6 things, again, depending a little bit on the time. I'm going to start off talking about the point of view of the whole talk, what we're trying to get at. I'm then going to talk about some challenges that are related to are an important aspect of interactions around race and ethnicity. I'm going to talk about systemic racism, which is something different from the idea of the belief of an individual person, but rather the way that racism is built into our society and built into the communities of which we're part, and which inevitably, I believe, comes into the individual therapeutic situation. And finally, if we have time, I'm going to talk about the hygiene of the therapist. What I'll talk about is the usefulness of self-awareness in this area. So we'll start and see how it goes. Let's start with the basic point of view. Regardless of the kind of therapy you do, regardless of your theoretical orientation, you can't do therapy unless a patient trusts you to a reasonable extent. I'm not talking about trusting you to believe that every word out of your mouth is some oracular statement, or that's brilliant, or that you're a wonderful person. The patient must trust you to the extent that they think you might well be on their side and you might be trying to do something useful. That's all. And without that degree of trust, no matter how slight, therapy is impossible. Now, what that implies is if one wants to have a patient at all, what one must do is see oneself as the patient sees you. You must see phenomena from the point of view of the patient. If you fail to do that, with good reason, no patient is going to trust you. Or maybe you can fool someone into trusting you. But when I walk into a room, an old white man with a beard, it is only a reasonable assumption that regardless of how I think I am or what I believe I am, that's the way my patient's going to see me. And the patient's decision about the question, can I trust this person, is going to be contingent on what the patient sees, not what I want them to see, not what I believe they should see. And this means that my conduct has to be consistent with something that makes me trustworthy. Now, if I do and say things that lead a patient to think, this guy sees me as someone who's other than him, or so different from him that he can't work with me, or looks down on me, or whatever the patient sees, insofar as I contribute to that, I interfere with the possibility of being trustworthy. And we human beings trust people on the basis of their actions, not on their statements. To say something like, I am not a racist, doesn't make me trustworthy to any reasonable person. to act in a way that is not only not racist, but is anti-racist, and I'll talk more about that, is to, through action, indicate that one is trustworthy. So, in short, what we're always looking at is what the patient sees and experiences, not what we intend or what we wish or what we believe about ourselves. What matters is what the patient experiences. So let's talk about, really, in a way, some interferences in being trustworthy. Will make patients quite reasonably mistrustful of us, or understandably mistrustful of us. And the first of these I put under the heading of ignorance. That is, there's a whole bunch of stuff that we don't know, certainly about the individual patient, and usually about the community from which they come. And this can create situations where being unwilling or having difficulty recognizing our ignorance, we have real cases of foot and mouth disease, where we say things that are sometimes stupid, sometimes simply unempathic, but sometimes just incredibly unuseful. So let me give an example from my own experience, again, from many years ago. I was a young woman from an Arab country, came to see me because she was very unhappy. She was aware that she had very strong sexual urges, and that those sexual urges were not being satisfied. It was a real problem for her. And we talked for 2 or 3 months, and I gave her the usual psychoanalytic stuff in one way or another, basically saying, conceptualizing what was going on, is that she was inhibited, and that her inhibitions had arisen from her early childhood experiences, and we talked about this in some depth, and I thought we were doing a wonderful job, until one day she came in and said, "You really don't understand, do you?" And I was and said, "So tell me." And she explained that her avoiding sexual relations was really very simple, that she and her family were from a rather rigid Islamic community, that it would be, if her brothers and fathers were to learn that she had sexual relations, it would be their obligation to stone her to death. I had no idea that this entered the picture at all. And obviously the conversation changed rather radically when I recognized that, at least for this particular patient, I was simply grossly ignorant of what was going on. Now, of course, it's not always that the ignorance is quite so blatant. And one source of profound ignorance is obviously the misinformation we have about other communities. That we've all grown up in environments where we've been told things about other communities. We've been told we turn on whatever channel we turn on, or open whatever newspaper we choose, and we hear statements about communities of various kinds. And a lot of it is simply not very accurate. But what's more important, I think, is that if you think about this information that you get about communities, even assuming it's accurate in terms of communities, it doesn't necessarily apply to the particular person you're speaking to. If you say that criminality is at such and such a level in a particular community, and you're talking to a member of that community, at best, all you have is a kind of probabilistic statement about that person. You really don't have any real information about that person. If you listen to yourself, or at least if I listen to myself, I often hear myself thinking and sometimes saying things like, Asian families are such and such. Okay. Or Black adolescents are such and such. Or white men are such and such. And none of those statements, even if the statements are statistically accurate, are particularly likely to be accurate about the particular person you're talking to. So there's a different kind, there's an additional kind of ignorance. There's the ignorance of simply not knowing, there's the ignorance of misinformation, and there's the ignorance that comes from assuming that being a member of an ethnic or racial group means anything in particular about the particular person you're talking to. So when you're ignorant, your patient or potential patient quite naturally is going to say, or should say, I doubt that I can trust this person. Why should I trust this person? And their judgment in that regard, I would say, is likely pretty good. They have every reason not to. I'll move on to a second major topic of microaggressions. And I'll again begin with an autobiographical story, because I think it may give you a feel for what I'm talking about. This happened to me when I was 8 or 9 years old. I had a best friend named Jack. I come from a New York Jewish background, which at least my version of it translates into someone who is identified as Jewish, isn't religious, and thinks the world is automatically left liberal to progressive, or should be. Okay, that's the way I thought of the world I came from. And of course, none of that was articulated when I was 8 or 9 years. Jackie was my good friend, and we were talking about something. And we were talking about some business transaction or something that had occurred in the store. And Jack used the phrase that the store owner had Jewed someone out of money. Now, and a few minutes later, when he said it, I literally didn't know what he meant. The term, which is common, is a reference to tricking someone in an immoral way, to cheating someone by being clever or whatnot. So the term is or was a common term, but I'd never heard it before. Jack, who was more sophisticated than me, a minute or two later apologized, which left me kind of puzzled, but alerted me to the fact that he had said something very negative about the group of people of which I was a member. Now, I'm sure he wouldn't have thought of himself as racist. I'm sure he wanted to be my friend. He continued to be my friend. But the friendship was never quite the same. I never had the feeling that I had before this, that this was someone I could trust implicitly. This was my buddy. This was a guy, we were, simply friends who could trust each other implicitly. This is an example of a not so micro, but still microaggression. If you want a good definition of it, it's a subtle, often unintentional comment or action that expresses a prejudiced attitude towards a member of a marginalized group. So when one says things that are like that, that we're looking at things from the point of view of the patient, not from our point of view. The question is, when we make a remark or use language that stimulates in the other person a experience of being marginalized, of being othered, of being treated as different or inferior, even if it's not our intention, that we are interfering with the trust that that person will have in us. The idea of microaggressions is particularly important because there's at this point, a vast and rather convincing social science literature, as well as clinical experience, that indicates that people who are subject to microaggressions experience them cumulatively. That it isn't the traumatic experience of being mislabeled or whatnot that's problematic. It's that this happens over and over again, and to the point where the person becomes exceedingly aware, painfully aware, that of microaggressions, and at the same time somewhat confused by them, because it's often not clear what the intent was. It just feels terrible. There's a beautiful example of this in a paper by Peggy Cooper Davis, who's currently a professor of law at New York University. And I'll give you her example. That this occurred, and she's a Black woman who at the time was a quite young. She was a public defender in New York City and was in a courthouse. She was standing in front of an elevator and intending to go down when the elevator came. And she was, at that point, the only Black person in the building who wasn't a defendant. That picture, young Black woman standing in front of an elevator. The elevator door opens. She wanted to go down. The elevator is going up. There's no one there who had, for some reason, it had opened on her floor going up, but there was no one who seemed to want to either leave the elevator or get on it. And there were some of her colleagues, white men wearing suits and ties, and one of them looks at her, and in a way which she experienced as having a look that meant to her, this was a stupid Black woman, or this was a criminal. The door, he didn't say anything. The door closed, and she felt terrible for a couple of days. Now, you can say again, well, do we have to lay blame on the man who looked at her? No, we don't. All we have to do, if we keep focused on the person's experience, on the patient's experience, is to notice what the effect is. And here I'll give another example, again, from my own experience. Dorothy Holmes is a Black woman analyst with a national reputation. She's which has grown in recent years considerably, and she's someone who I know slightly. Another Black woman analyst came up to me at a meeting of the American Psychoanalytic Association. I'm really lousy with names. I've always been lousy with names. I don't remember names. It's not something I wish was different, but it's true of me. And I said to this Black woman analyst, "Hi, Dorothy." At which point my colleague looked down and said, with real sadness, "We all look the same, don't we?" Now, she was aware, and I was aware, that it wasn't my intent to hurt, but in fact, I did hurt. That my slip was painful to her. We we could interpret it in many ways, but the fact that it was painful to her was the information that I want to get across about microaggressions, because it happens over and over again, I think, in many therapeutic situations where the therapist says things which are painful, othering, sometimes out of some unconscious motivation, sometimes probably without much motivation. Again, this is particularly likely to happen in situations where we're ignorant of the meaning of what we're saying. So that, for example, a Black gentleman who was studying at the Analytic Institute and liked to talk a lot, was going on about something, and the teacher said, "I'm going to cut you off." A phrase which has powerful meaning, or certainly for this patient and to many Black people, "I'm going to cut you off," which left the patient or the student feeling absolutely terrible and mistrustful of the teacher. Now, going back to my example with my Hi Dorothy, I want to say something that I think might be helpful to you all as therapists. One way be, and it certainly occurred in me to apologize, certainly, but at the same time to think to myself, oh, I'm not a racist. You know, I have nothing but, as far as race goes, but benign thoughts about these two Black women, confusing them to sort of just, I'm this innocent guy. And maybe I am. But that's not a particularly useful stance. I'm forever grateful to my colleague who spoke in the way she did, because it gave me an opportunity to learn from experience, to learn what the meaning of what I do was. It gave me a chance to perhaps develop in certain ways. So here again, one can change the position around. When confronted with the fact that one is engaged in microaggression, that's a chance to learn. That's a chance to learn from experience. And I can say genuinely that I'm grateful to my colleague who let me know of how I had pained her and how I needed to understand that, again, maybe in everyday life, but certainly in working with patients. Now, I want to move on to systemic racism, because it's a term which confuses people enormously. So I'll define it. Systemic racism refers to a complex system of policies, practices, attitudes that perpetuate racial inequality and discrimination within a society or organization. Systemic racism is not the mental state of an individual. It's a situation, it's a group of situations that keep people outside. It can be all the way from exclusion from a community to having policies that don't include people who are not, in quotes, like us, to attitudes or actions which disadvantage those people. Now, what this does, I would argue, this is internalized by many of us, and we become actors in systemic racism, whether we want to or not. That it often is invisible. It's normal that certain people have certain positions. So sometimes it takes the form of talking about one's own community as if it were superior, and thinking these people are not like us, and it just, in quote, happens to correspond to the society in which we come from. It doesn't just happen to. It's part of what we've been educated to from day one. We've all been exposed to stereotyping that has from early childhood. We've all been in situations where even if we're opposed to policies that hurt other people, we say, well, you know, that's a problem, but how much energy do I want to put into that problem? Well, if someone were shooting you, murdering you, or people who look like you, and someone said, oh, I don't know that I want to put too much energy into that problem. That's sort of the problem of the people who are being murdered. And I want to get to class, or I want to get to my job. That doesn't sound, well, that sounds good, but it is an internalized view of the world in which one is cooperating with horrible things. And Ben, this is not an attempt to convince you to do otherwise, because if nothing else, I can't convince myself to do otherwise to a large extent. But it is an attempt to make you aware that your patient quite reasonably will often assume that your attitude, you have a group of attitudes which correspond to the community of which you're a part. And that assumption, through their eyes, is going to make you not trustworthy. Now, I'll just say one or two words about the sort of mental hygiene of therapists, and maybe that we can talk about this more in the discussion, because obviously, if one's unaware of what one's communicating, of how one will be seen, then the situation becomes hopeless. And you won't get anywhere with it. The awareness of one's own, I'll call it racialized behaviors. I'm not going to call it racism. That's not what I'm talking about. I'm not talking about whatever's going on in your head. I'm talking about what the patient sees and experiences. The awareness of that is, it seems to me, absolutely vital if one's to address it. And the awareness that one's likely to communicate that people are other, that they're not like you, that they're not to talk in ways that aren't trustworthy, is, I would argue, in the first place, quite natural. That if my 16-month-old granddaughter came to visit from Arizona over the weekend. She's a lovely child. She's a marvel. And I now bent down and said, "Hello, Cora," and wanted to kiss her. And she looked at me like this was the weirdest, most dangerous thing she'd ever seen, immediately covered her face, turned away, which is, by the way, absolutely normal behavior for a 16-month-old. And only very gradually over the course of an hour or so began to first, maybe I wasn't dangerous, but I was this weird looking thing that was coming at her. And she quite naturally said, "That's other, that's dangerous." And that's built into all of us. That and is probably necessary for survival. Now, I'll talk, hopefully in the course of conversation, we can talk about this more, but something I would advocate to you very strongly is, if you allow yourself to do so, your patients will educate you about what you're doing. They'll educate you about what their experience of you is. If you don't allow that to happen, well, one, you'll remain ignorant and less effective. Two, a certain number of patients will quite reasonably say, in one way or another, maybe not grossly, but in one way or another, they'll say, "This is not a person I can talk to. This is not a person who I can trust, because from my point of view, they aren't willing to see me as I actually am." In parenthesis, this is not about self-psychology. This is not about some hot analytic theory. This is about just ordinary human interactions. So hopefully I haven't bludgeoned you too much with this. Why don't we open it up for conversation?
And you can ask your questions or send your comments, either unmute yourself and speak. And I have to imagine there are many thoughts or reactions or responses, because the material is so sort of subtle and rich.
I have a question. Bob, do you remember from 30 some odd years ago how you responded to that woman who came in and said, "I'm not what it is that you think I am"?
Yeah, yes, I do remember how I responded. My first was because she was so clear and articulate. Uh, my my initial internal response was surprise, and followed in this particular instance by the thought she was probably, I was sure she was right, because I had a whole sort of scenario about her that I hadn't made explicit to myself, but if I was aware that if someone had asked me, who is this person you're talking to, my response would have been sort of a description of my fantasy of what a person who looked like that would be like. And as it happened, rather fortunately, I immediately recognized that this was an opportunity to learn something, and that I got the lesson she was trying to teach me. What I did verbally was to say, using her name, I'll do my best to try to know who you actually are. And that was the beginning of a very, very good alliance. Mark?
Yeah, hi, Bob. Thank you. Your colleague that I'm going to use the term called you out, because that's part of the phraseology of some of the literature I read about confronting, whether it's microaggressions or worse. And there's another term you did not use, racial enactment. So I just want to raise that and see if you can, if we can open up a little this dilemma of when to do that, how to respond to that in different situations. One that comes up more is there's a lot of teaching or literature about if there is like a racial difference in a treatment, that if you don't bring it up as the therapist, you're somehow not doing your job, whereas a lot of us were trained, you don't really bring things up necessarily, the patient brings things up. And I mean, I think of Charles Brenner, who obviously is a deceased but respected from an analyst from another generation, but he used to really almost brag about treating Holocaust survivors and not bringing up the Holocaust.
Yeah. So
to go to his memorial, I happen to be in New York, and one of it. Go ahead.
Oh, okay. So I think this is actually a lovely example of a not so microaggression. That is, one can be aggressively silent, to be, for example, talking to a Holocaust survivor and wait for that person to bring it up is I think simply cruel. If I walked into my analyst's office and I was bleeding, and my analyst waited for me to say, "Oh, I'm feeling so bad because I'm bleeding and you haven't noticed it." You know, I fired that analyst at that point.
What Charles Brenner, and I don't know how many patients like this he had, or if it's the one I heard him talking, but she was a Holocaust survivor. She had been his patient. She spoke at his memorial, and she thanked him, obviously after the fact, for not bringing this up, because your assumption that she was bleeding, apparently that's not how she felt. So again, how do you know? How do you make these judgments about these things?
Well, you make the judgment in a way commonsensically. Let's use the example of bleeding. It's quite possible that the person would say, or let's use your example, that the person would indeed be grateful to Brenner for not bringing it up. I can imagine that. And would experience being defined as a Holocaust survivor as a kind of othering that was destructive. But observing something about someone, saying something about something that's obvious, is not an imposition unless you make it one. That is, if Brenner had said, or someone had said to a Holocaust survivor, "This is the main fact about you," implicitly, this is the most important thing about you. What defines you is that you're a Holocaust survivor, or what defines you is that you're Black, or that you're Muslim, or whatever. That then the patient would say, legitimately couldn't trust you. But if you ignore things that are obvious, then the patient also can't trust you. So if we can imagine a long period of time when the patient didn't refer to being a Holocaust survivor, the question, a reasonable question would be, it's interesting, we've been talking for 5 years now, and what would seem to me to be a very painful experience I wonder about that.
That sounds fair.
Yeah. Yes.
And how do you feel about, so on the racial difference, do you feel like if there's a difference, is it your duty, if the patient doesn't bring it up, to bring it up?
Yeah, because if one's talking seriously to someone, and it needn't be even particularly racial, or it can be religious, it can be I gave this example of my growing up in New York, the neighborhood I grew up in, which and it if you went 2 blocks west of where I lived, you were in a completely different neighborhood. And with a completely different story. And if I were somehow to have an analysis from that neighborhood, and I started out, oh, we're New Yorkers, we come from the same place, and might well say that. And then, well, now we're a year into the analysis, and the fact that he comes from an Irish Catholic background with a very strong anti-Semitic element in his culture, and I'm this Jewish guy, and there's been no mention of that. It would be weird to pretend that there was nothing going on. Now, maybe there isn't, but unless I would think, yeah, I'd bring it up. Jesse?
So thanks, Bob, for sharing your thoughts about this complicated issue, and especially sharing your personal experiences to illustrate some of the things we need to be considering. The question I have is, given that everybody has a unique, emotional experience, and that patients, are inevitably going to have experiences that we share in and know about, and that inevitably leads to narcissistic injuries that we impose on people, empathic failures. Those often become the richest moments in treatment, and become healing experiences, not just for the patient, but for ourselves if we're kind of all in, in our work. My experience with when those disruptions involve race, that it often has a volatility and intensity, a ferocity to it that feels like it never can really come back together, that Humpty Dumpty, can't be put back together. And I wonder if you have some thoughts about how injuries in this domain that's different than the other ways in which we, often can't find each other, when doing the work.
Yeah, I think that the one reason there is such a difference is that both for patient and therapist, the experiences about race are so often not resolved in their life experience, that the process of racial issues coming into focus and then being worked out is simply not an everyday experience for most of us. And whereas, for example, more other types of narcissistic injuries, there's a kind of social expectation of, oh, well, if we work at it, we may be able to work it out. And I think that actually it isn't so much that the racial issues come into the situation and make it volatile. I think what happens is that when racial issues come in, it's an indication that one's sitting on a volcano to start with. And experiences where indeed the therapy will fall apart, but I think it's often because the therapy has already fallen apart. It's just been done so quietly, where one is politely pretending to get along. I think a very practical application of this is that some patients, and of course, this doesn't just apply to race and ethnicity, will say, you know, I really can't work with someone who I don't believe understands my experience. And I think the therapist's legitimate response to that is to say, yeah, maybe you're right. And maybe we can certainly think about that together and think about whether it might be possible for us to work together. But sometimes what seems like an explosion is really the surfacing of the reality that the patient can't find a way to make the therapist useful, or the therapist can't find a way to make themselves useful. And confronting that is, I think, a good thing in the long run. I've certainly had patients who have said to me, you know, I need to talk to someone who is close enough to my experience that I can't bring myself to really trust you, given who you are. And I'm not sure they're wrong. One other thought about this. I think when that happens, spending a lot of time trying to convince the patient that you're really okay is a real mistake, because one can sometimes seduce the patient into staying or talking nicely and whatnot. But in the first place, it's often untrue that there are certain patients, there are certainly, again, I'll give an example. This is from a forensic context, but I was working with a defense attorney who was defending a young man who was literally a terrorist and had been arrested because he had a bunch of rocket launchers in his basement in Skokie. And I was assigned the task of interviewing him to see whether he had a not guilty by reason of insanity defense. And so I go to the federal lockup in the Loop. I'm locked in a room with this guy, and I say very, very nicely and as politely as I can, Mr. So-and-so, for me, my job is to such and such, give him the usual blather. And I listened to him, all the time being terrified. I had absolutely, and I think my terror was probably justified. his goal was to kill in life was to kill as many Jews as he could, and here I was, this Jew locked in a room with him. You know, there are situations where it can't work, and recognizing that, I think, is also useful. Yeah. Nancy?
Yes, hi, thank you. Can you hear me?
Yes, I can.
Okay, thanks so much for your talk this evening, and I'm really getting a lot out of the conversation. And I think we just have a few minutes, but I wondered if you could comment on a situation where when there is in the consultation room, white analyst, white patient, and the patient says some very offensive things, very racialized comments, and kind of how to address that with the patient without, and also when I have tried to address that with this particular patient, he complains that I'm kind of doing narrative takeover, then talking about this other thing, and he wasn't even talking about that. Why are we now talking about what I want to talk about? Very, very difficult situation that happens repeatedly.
Yeah, and I think there are a few thoughts about this. One is that it is indeed not our business to fight racism or homophobia or Islamophobia or whatever. That's not why our patients come to us. And that's not part of our contract. So now I would approach, here's the way, part of the way I would think about this particular situation. Given that the patient obviously knows you find this kind of talk offensive, the question I'd be asking myself is, why is this patient assaulting me? Why? I think of it as a transference enactment, or an aspect of the transference, rather than thinking about the particular content. And if you think about it, angry enough patients or hostile enough patients, learn what presses your buttons, and they do it. So that would be one thought. The other thought is that it's a couple of variations on this thought. Another thought is that the patient is actually in pain with this stuff. To walk around thinking that the people you're bumping into in the street are, let's say, murderers or whatnot, that's an awful way to live. So rather than thinking of it as doing away with their fantasies, it's I don't want to be too political in this context, but I would not like to be Donald Trump. I would not like to believe that there are all these awful people who are trying to. So that when people express hostility like this, racialized hostility, it's often an expression of something, of a position that's really painful to be in, although they express it in this sort of assertion about the other. A third thing is that, of course, white people, just like everyone else, have an awful lot, very, very often have or can have, I want to be careful not to overgeneralize, but can have a situation where they feel very, very vulnerable. When I was planning this talk, there's a now I'm giving away my age, which is great, but there was a popular song by a group called Limp Bizkit called "Behind Blue Eyes," and in which this tattooed, rather muscular singer is singing. No one knows what it's like to be a sad man behind blue eyes. That is a white person who's seen as white, who is not understood to be in the kind of pain. So I think often the racist one reason for racist content is, can't you see how, in what pain I'm in, being stereotyped, being seen myself as though I were inhuman because I happen to have blue eyes. It's something to think about. So there are sort of three things that I come up with that particular situation.
Thank you. Very relevant.
It is time for us to close for today, although I think the conversation could go on for another 2 hours easily. One thing I really appreciate about you, Dr. Galatzer-Levy, is how you approach things in a way that asks us to think about ourselves. And as you said at the beginning, not in a prescriptive way, or you should do this, but tuning into what our own experience is and how we can fine tune that as a therapist. I really appreciate.
Thanks very much. I hope it's a way I've learned to think about things in part from the experience. And again, I could at least go on for another 2 hours of doing klutzy things and feeling guilty about them afterwards. And if one lets oneself learn from experience, it's really it's a way of making being a therapist joyful and valuable. So I'm an advocate for it.
Thank you.
Thanks so much.
Okay. Thank you very much.
Thank you.
Thanks, everybody.